Morning, everyone. The participant numbers are ticking up, so we'll give it a minute or so. Um, and then once that steadies a bit, we'll kick off. And it's great to see so many people online. So, morning, everybody. Thank you so much for joining. You'll see a few instructions on there. So you'll be automatically muted, and also the camera will be off, so no need to worry about any of that. But the main thing is that there is a Q&A function, which you should be able to see at the bottom of your screen. And I really encourage you to pile in the questions there, and we'll hopefully have at least half an hour, if not more, to be able to spend most of the time discussing some of your questions and obviously those thoughts and insights from our panelists today. So, good morning. My name is Adam Briggs. I'm a Senior Policy Fellow at the Health Foundation, and I'm absolutely thrilled to be able to introduce today's webinar. We have three fabulous public health leaders joining us. We have Alice Wiseman, who is Vice President of the Association of Directors of Public Health and also Director of Public Health for Newcastle and Gateshead. We have Shannon Cotillo, who is Director of Public Health for the London boroughs of Richmond and Wandsworth. And we also have Janelle De Grucci, who is the Deputy Chief Medical Officer and Joint Lead at the Office for Health Improvement and Disparities at the Department of Health and Social Care. So the way today we're going to take it forward, I'm going to give a short introduction to the topic and what we're exploring today, and also a bit of background to the Health Foundation. And then I'm going to invite each of our speakers in turn to think about, firstly, what they've been able to do in their workplace, in their contexts, to tackle the leading risk factors for ill health, and particularly about how local authorities can take action to create healthier places that support everybody to stay well and to prevent disease. And then secondly, we're going to hopefully spend some time thinking about what more could be done and what changes would support local authorities to go further to best meet some of the challenges that they're facing related to tobacco, alcohol, and unhealthy food. And also, I sneak this in beyond our comms team. There's a little bit of municipal architecture there. That's County Hall at Oxfordshire County Council, which is where I spend half my week as Deputy Director of Public Health. And as of next week, you can look at the marketing plan and see if you want to place a bid. Anyway, on we go. So the Health Foundation. The Health Foundation is an independent charity, and our mission is to bring about better health and care for people in the UK. And we do this through a number of ways. So firstly, it's about conducting research and analysis. We do a lot of shaping of policy and practice by working with local and national government. We have a large part of our work is about trying to build skills, capabilities, and knowledge, and ultimately it's about trying to catalyse change. We do have three broad areas of work at the moment. These are the boxes in the middle. It's about improving health and reducing inequalities, which focuses on the wider determinants of health and also on the risk factors that we're covering today. Looking at innovation and improvement for health and care. And then finally, providing evidence and analysis to improve health and care policy. So today we're looking at how local authorities can tackle the leading risk factors for ill health. And those leading risk factors are tobacco, alcohol, and unhealthy food. And so the context within which we're looking at this is over the past decade or so, there's been a lot of work done and a lot of work funded nationally trying to reduce harm from these three risk factors. But predominantly, they've focused on individual behavior change. So supporting people who either already smoke or already drink harmful amounts of alcohol to support those individuals to change their behavior, as well as around advertising campaigns, again, aimed at trying to change people's behaviors. And there's been less of a focus on some of the population level changes that we know can be most effective and equitable when we're trying to create places that can prevent people from becoming unwell in the first place, or from taking up smoking, or from their exposure to unhealthy food. We also know that over the previous government, and then we'll talk about the current government in a moment, there's been a growing interest in devolution and the role of local leadership in tackling some of these health issues. And this is supported also, the role of national government is supported by some of our polling work that we've done looking at public attitudes. And this slide shows the majority of the public see the state, so see national government as having responsibility for addressing a lot of the main risk factors for ill health. And there is some variation, but you can see there's generally really significant support for national government having a great or a fair amount of responsibility for the breadth of these risk factors, including smoking, unhealthy food, and alcohol. However, at the same time, the public generally thinks that national government isn't doing enough. And the one exception there, which may not surprise you, is reducing harm from tobacco, where we've seen an awful lot of shift in some national action on that recently, particularly with the tobacco and vapes bill that will be coming back to Parliament soon, and the smoke-free generation policy. And then when you begin to get into some of the specific policies that national government might be able to take forward, and I appreciate this is a very small worded slide, but it's meant to be illustrative if nothing else. And the top two bars are tobacco policies, the top one being the smoke-free generation policy. That's increasing the age at which you can legally be sold tobacco by 1 year every year. Shows in red and pink the strongly support and tend to support far outweighs the tend to oppose and strongly oppose in blue on the right-hand side for public support for that policy. And you can see across the breadth of alcohol policies in the middle, which includes minimum unit pricing, which is the very middle bar, and also unhealthy policies to tackle unhealthy food. So we have the ban on advertising of unhealthy food on television and also online as the third up from the bottom, that generally, again, these are policies that have broad public support, hopefully adding a little bit of weight to the national opportunities to take some of these policies moving forward. And we've seen a lot of positive noise in that area recently. However, over those past decade where some of this stuff hasn't been taken forward, we've also seen local authorities try and do more in this space and become more innovative. And again, that's supported by some of our polling showing that 55% of the public support local authorities having a greater responsibility to implement policies to reduce harm from these risk factors, with just 21% opposing. So what can they do? And what is already being done? I think the first thing to note is the hugely constrained context that local authorities are operating in, and many of you on this call will understand that all too well. So we've seen that there's been over a 30% reduction in central government grants to local government. We've also, at the same time, seen around a 10 to 11% reduction in the spending power of local authorities once you take into account some of the revenue-raising approaches that have been taken as a result of reduction in central grant. We've seen a 28% reduction in the public health grant per person in real terms over the same decade, and also a growing demand and often cost of a lot of the statutory services that local authorities provide, particularly in children and adults. Also, I want to really highlight some of the workforce and skills challenges facing local authorities, particularly in the kind of professions that are essential to local authorities taking the action against these risk factors. So we know that, for example, in trading standards, we've seen a 50% fall in the number of trading standards officers in local government in the decade from 2008-9. And also 50% of local authorities report unfilled environmental health officer posts for more than 6 months. So within that context, it's remarkable how much is actually being done. And we did a very large review of all the work that is being taken forward across local government and buckets the kind of work that's going on into 3 broad areas: about role modelling change, which is their commissioning work, using their buildings or their investments and conflict of interest policies; about system leadership and partnerships. So that's through agreements with local businesses or other local organisations, as well as the leadership roles that local government leaders can take in advocating for change nationally and within their place. And then also their legislative responsibilities, whether that's in planning, licensing, or enforcement. And within this piece of work, there's some really fabulous examples in the appendix I want to draw your attention to about what's being done at the moment, the kind of the places that are taking forward some of this action, and then also importantly, the legislative context that enables local government action, which hopefully should provide some of the support for councillors and officers working in this space to be able to do more where they think they can. And then there's a whole host of resources. However, one of the things we found when we did this piece of work is that often there was some frustration about the length to which local authority action could take and some of the barriers to doing more. So we did a further piece of work where we reviewed policies that have been put forward by a range of national and local organisations within public health, but also within the broader professional bodies that work within local government, as well as in the charitable sector, to identify the kind of policy approaches that might enable local government to take further action. And then we prioritise these along with a range of colleagues working across the system against the potential impacts that these policies might have on health and on inequalities, the political feasibility of implementation, the practical feasibility, so what legislative change has to happen, and then the cost. And we landed on 5 potential policies. And I don't think many of these will be a huge surprise to you. But one of the things that I think is really encouraging and that hopefully Janelle will be able to talk a little bit more to today is we've already seen that with the National Planning Policy Framework consultation being one of the first things that the new government has brought in, that the rhetoric around potentially enabling local authorities to take more action and being more permissive in what they can do to support health, whether it's around hot food takeaways or anything else, seems to be potentially bearing fruit. So that brings me to today. So as I say, I'm absolutely thrilled to have today's speakers. I'm going to start with Alice, and then I'll come to Shannon and Janelle in turn. And each of our colleagues are going to speak about the work they've been able to do in their local areas and what has gone really well with that, but also to hopefully surface some of the challenges that they've encountered when taking forward some of this work, and what might make some of the what might help them overcome some of those challenges to be able to go further. So I'm going to stop sharing my slides, and I'm going to first, if possible, invite Alice to talk to us for around 10 minutes. And please do keep filling in your questions, and then I will be selecting some of those once we've heard from each speaker. So thank you. Over to Alice.
Thanks, Adam. And it's really good to be here and great to see so many people interested in this really important agenda. I kind of, just as a start, I often reflect on, kind of public health moving back into local government and, the opportunity that gave us to start to think about how we can tackle some of these in a broader context. And if you look back at the kind of history around public health and, our need to tackle things like communicable disease sort of several decades ago, and actually we've got the new challenge of non-communicable diseases now, and the only way that we're going to be able to improve health across the population if we start to take some of these issues seriously. So,
Alice, sorry to interrupt. There's a few people saying it's struggling to hear you very well. I don't know if you're able to come closer to your microphone or...
I'm on my laptop. Is that any
Okay, yes. Yeah, just speak a bit louder. I think that's great. Thank you.
Speak a bit louder. Apologies for that. I've normally got a really loud voice, so it shouldn't be a problem. So just in terms of that broader context. So I think that this is a space that we absolutely need to be getting into. And the starting point, I think, is to understand what we've managed to achieve as a public health community over the last couple of decades in relation to smoking prevalence and action on smoking. And I think the reason why I start there is because I think there's so much learning that we can then apply to some of these other issues that we've got that are affecting an increase in non-communicable diseases. And if you look back at the last couple of decades, and I know this started way beyond the last couple of decades, and the work that's happened, in terms of regulation and at a national level, a lot of that work started locally. So if you look at the smoke-free legislation, I know it was Liverpool, I think, who first stepped forward and said we want to be a smoke-free city. And it was the driver of local areas who were brave enough to stand up and address some of these issues that meant that we actually had the ability to have that conversation nationally. And then I also reflect on the fact that in 1962, around more than half of our population smoked. And at that point, we were kind of told, that nobody was really interested. It was a product that people liked and they enjoyed it. And I feel like we have some of those messages that we hear today, particularly in relation to alcohol. And it must have been really kind of distressing for our public health predecessors to continue to work on an agenda that they knew was going to make a difference, despite lots of opposition in the early days. So I guess I always kind of hang myself on the fact that public health predecessors have done a great work with tobacco. There's a bit more we can do, and I think that we have a great opportunity over the next few months. So I don't want to lose sight of that. But equally, what can we learn from that? And so there are two examples that I'm going to give you from the local areas that I represent. One, which, I've been in the DPH in Gateshead since 2016. And in 2015, actually, I was a consultant in public health in Gateshead, and we developed a supplementary planning document through the planning framework to allow us to consider levels of childhood obesity in relation to hot food takeaway applications. So the way we got to that was really, having those conversations with local politicians, making sure that local politicians understood the evidence base about the environment and the obesogenic environment and how that influences choices. Our industry would love us to think that it's all about individual choices and people making individual decisions, but we know, and we all know in public health, about how the environment shapes the decisions that we make. But not everybody does know that. And so in relation to that piece of work, there was a lot of work that happened in the early days, which was around ensuring both officers across the council in wider directorates, such as our planning teams, but also our elected members really understood that, and then felt able and confident to be able to take that action. In Gateshead, it was started again through a comprehensive strategy. So there was a full strategy around where we wanted to be in 2030. And in that there were actions included around addressing the issue of childhood, particularly childhood obesity. Our environmental health colleagues did some nutritional analysis so that we actually understood the content of the food that was being sold in hot food takeaways locally in Gateshead. And I think this was a really important trigger in being able to have some of those wider conversations, but being able to demonstrate that this food was, absolutely unhealthy. It always shocked me that there was one where they tested a pizza and it was 3 times a woman's daily recommended allowance of fat in one pizza. So I just think that sort of like evidence locally gave us the ability to be able to take some of those steps forward. I have to say our planning colleagues were ahead of the game and were absolutely, driving this as an agenda. So it never felt when we came in as public health that we were having to push it. It was absolutely a collaboration across the council, environmental health, public health and planners. And we have a joint, with a local plan, was a joint strategy across Newcastle and Gateshead at that point. So the development that we managed to achieve was and it came into force back in 2015. And we included where, that we weren't allowed to have any new hot food takeaways, similar to other areas. And I know there's many other areas done this now within 400 metres around a school, youth centres, leisure centres, parks. We wanted to look at the concentration, and this was probably more the planner's advice than the public health, but in terms of the frontage on shopping areas. But also we looked at the issue of obesity. So when we used our National Child Measurement Programme, when we said our target in our local strategy was to reduce the prevalence of overweight and obesity to below 10%. And sadly, all of our wards in Gateshead have a prevalence that is above 10%. And also around proliferation of takeaways, understanding that there are more takeaways in our more deprived areas. And we're really, it's really great that this supplementary planning document was accepted. And like I say, this goes back to 2015. And as it stands, we have not had a new hot food takeaway planning application granted in Gateshead. And whilst we know that planning is almost like closing the stable door after the horse has bolted in some ways, because we knew we had too many hot food takeaways in the borough. What it has seen is it has seen a reduction in prevalence of hot food takeaways as people took over the buildings and changed the use of them. They have not been able to then revert back and use them as a hot food takeaway. So I think that, that has been really, really helpful in terms of helping us to take a step forward on that hot food takeaway work. We have had 8 challenges to that. And 6 of those 8 challenges have been upheld solely on the basis of the obesity rates in the area. So I think it was really that sort of mapping between, what's our local ambition for childhood obesity? What is the evidence that shows that this food is particularly unhealthy? What's the evidence? And we use a lot of evidence from Cambridge Uni, who've done a lot of work around, transition or travel to and from work and what that currently looks like. And then, making sure it was part of that broader council strategy. And I think that that has meant that we've been successful in the appeals that have come forward. Although I have to say, locally, I do know that there are other areas who've developed policies that are as robust and as good and maybe haven't had the success that we've had with the local inspector. So there is still something that is needed at a national level to ensure that there is, sort of parity in the way that these appeals are being considered. And then the other example that I will give you is from Newcastle. And I've only been DPH in Newcastle since the 1st of April, so I absolutely can't take any of the credit for this work. And I guess the other point that I would make at this stage is going back to the Health Foundation documents. We stole this from Leeds. So if there's anybody from Leeds on the call now, this is something that we stole from you in terms of being able to implement it locally. It was one of the examples that was used in the Health Foundation documents that Adam and the team have produced. So I think there is no shaming stealing good practice and implementing it in local areas. And so that's a kind of, I guess, an important lesson for us as a public health community, is that, if people have had the ability to go ahead and do something that works, let's just use it and apply it in as many places as possible. So it was an alcohol data matrix, and really, since 2013 as a DPH, I have the opportunity to act as a responsible authority to put in a concern or an issue if there is a new license application. But I can only do it currently on the 4 licensing objectives, of prevention of crime and disorder, public safety, prevention of public nuisance, and protection of children from harm. It would be great if we could have health in there as a licensing objective. What we've seen in Newcastle, and it's a big city, so it is notorious for being a bit of a party city. But we've seen an increase in premises license over the last decade. And actually, what we all know as well is the evidence where there is higher prevalence of outlets, of licenses, that actually there's greater levels of harm. So again, being able to use our public health evidence and our public health intelligence to be able to feed back to that. So basically the team, like I say, stole this from a different area, from Leeds. And what we've managed to do is develop a tool that is now used locally, where our licensing colleagues rather can literally stick in the postcode for a new license application, and it generates all of the harm data related to the 4 licensing objectives that we've got. And it enables people to be able to make much better informed, much better evidence-based decisions on whether they can grant a license or not. I think there is more work to do, and I know I'm running out of my time, so I'll maybe pause now, but there's lots more I think we could be doing. And I certainly think that the one thing I haven't covered is the work around advocacy. So if I get a chance in the Q&A at the end, I'll talk about some of the work that we've been doing as a North East community around advocacy for wider measures to impact on these challenges. So I hope that's okay, Adam.
That's fabulous. Thank you, Alice. Really super. And there's various questions in the Q&A that are coming through about wanting to see some of your strategy work that you've done in Gateshead on healthy food. So maybe a chance to respond to some of those. Brilliant. So I'm going to come to Shannon now, if that's okay, to talk through some of the work that's been going on in London.
Thank you very much, Adam. Thank you for inviting me to speak, and it's great to see so many people on the webinar. I'm going to talk a little bit about what we're doing in Richmond and Wandsworth and share some of our learning. I've worked across both boroughs since 2018 and as DPH since 2020. So just for a little bit of context, Richmond and Wandsworth are 2 distinctly different London boroughs that happen to share a boundary, and between them have a combined population of around 525,000 residents. Richmond upon Thames, for those of you who know it, is one of the most affluent boroughs in London, with over 100 parks taking up a great deal of the borough, and it has an aging population, whereas Wandsworth is a larger inner London borough with more built-up areas. The population is very mobile, young, with a median age of around 33, educated and economically active. So around 3 years ago, both councils developed and adopted a prevention framework, and I'll just ask colleagues to put that slide up as I speak to it. Our prevention framework was developed as a health in all policies approach to embed prevention and address health inequalities. And actually, it was based on some of the OHID guidance that has been produced on place-based approaches to reduce health inequalities. I'm just checking to see whether that slide has come up. Yes, it has, or it is. So our prevention framework is actually the basis for a lot of the work that my public health team does in collaboration with other parts of the council and with wider system partners. And I'll just describe it briefly before going into some of the examples. Do I need to share the slide or is it coming up? I'll carry on.
I've just shared my screen.
It's not the right slide, Sonia, that's all.
Oh, sorry.
So that's fine. I'll start describing it anyway, and hopefully it will come up and it will all make sense. So the key objectives of both councils' prevention framework are to deliver an evidence-based approach to prevention, to support the wider council to strengthen delivery of prevention through its work, and helping everyone to recognize the role that they contribute to the prevention agenda.
Thanks for that, Edvi.
Thank you. The second objective is to facilitate making the healthy choice the easy choice. And then the third objective is to support a tailored approach to prevention. The fourth objective is to connect it with policies and initiatives that enable prevention work to be sustainable. And just lastly, to create supportive communities and health promoting environments. So the framework is in front of you there, and you can see that it's based on 7 principles. I won't go through all of them. And then it also works at 3 interconnected levels, which are healthy people, healthy places, and healthy environments, really encouraging anyone who's using the framework and embedding it to think about what action can be taken at all those different levels. So it has several delivery mechanisms or vehicles. It can be embedded into plans, into policies, strategies, or services. And actually, 3 years later, we've got some very good examples around how we've managed to embed this framework across different parts of the council, like planning policy. It's been embedded into things like our leisure strategies and so on. So if you can take the slide down, I'll just go into some of the examples of the work that we're doing based on the prevention framework around some of these health determinants. So we've just heard, about alcohol, this is an issue for us in Richmond and Wandsworth, and a priority area in both the joint local health and wellbeing strategies. In Wandsworth, alcohol-related mortality is higher than the national average. And in Richmond, the numbers have been steadily increasing over the last 3 years. So 1 in 3 adults in Richmond drink over the recommended units of alcohol in a week. And actually, the number of licensed premises that we have per square kilometre in Richmond is significantly higher than the England average. I would think probably in the top 10. We're also using an alcohol licensing dashboard and a new pilot pathway to create healthier environments, if you think of the prevention framework that I just had on the screen. And the dashboard and the pathway draw on some of the principles of that prevention framework. And I'll give 3 examples just to highlight that. So if you think about the 7 principles that were on the screen, one of the principles that the dashboard and the pathway draw on is evidence-based action, because the dashboard is a tool which translates some of our local crime, demographic, and health data into a simple RAG rating that can inform licensing decisions when applications are received. The second principle it draws on is around partnership and collaboration. The dashboard is part of a new pilot pathway which involves close collaboration between public health, the licensing team, and a pool of council analysts who sit centrally within the council. So that means that they've got access to all sorts of different data sets and intelligence that the council holds. So as you know, and I think this has been mentioned, statutory licensing objectives don't include a health objective. So as a public health team, we're working to a greater extent because I think, as a public health team, we're uniquely placed to provide a view on how the 4 objectives that Alice mentioned interact with health. For example, through sharing evidence on rates of domestic abuse and linking that to alcohol consumption in a particular area. The third principle that we draw on is around reducing health inequalities, because we know that people living in the deprived areas are more likely to experience alcohol-related hospital admissions or die of an alcohol-related cause. So what has been our learning and some of the challenges? Well, firstly, I think I'm really pleased that, we've had a really good experience in terms of the collaboration between different partners and teams in the council. And I think they've been very open to kind of having this evidence-based approach, but also the support that we've offered them in terms of how they can demonstrate that they're embedding the council's prevention framework within their work. Obviously, this is a really complex area. It's quite challenging to try and prove direct impact on health of a single licensing application when it's presented. And, compared to some of the other legislative objectives that have been mentioned, there's a little bit more evidence around that can link, that evidence to a particular geography. And I think sometimes this issue is compounded by the fact that, some of the data is difficult to find, or when you get it, there's a bit of a time lag, which doesn't really help, if you're trying to provide evidence around a particular application. And so I think that, the cumulative impact on health could probably be a more objective consideration that is easier to evidence. And just finally, I think one of our learnings has been the conflict of interest between, the economic interest and the agenda around commercial growth versus, the health objectives. Because obviously, want new businesses in the area. Businesses can bring a lot of benefits we're aware of, not least to mention business rates. But depending on the nature of the business, this can also have an impact on health. So it's just part of that kind of landscape that we have to negotiate. And then I'll give just a couple of other brief examples before I summarize. So we've got other examples as well across Richmond and Wandsworth where we're working to address, the proliferation of unhealthy food. And one example is our healthy catering commitment, where through our environmental health colleagues, we're working with food businesses to support residents to have access to healthier, nutritious food when they're eating out. And the scheme encourages business to commit to reducing levels of saturated fat, salt, and sugar in the food that's sold on their premises. Obviously, it's great for the businesses if they can, advertise themselves as, having a healthy food offer, and it also meets the health objectives that we're trying to address. In terms of tobacco, we've been working with local communities through Wandsworth Health Bus. We've had the health bus for a while now, delivering all sorts of health interventions, but particularly around tobacco, we've been using it to provide on-the-spot consultations and information around smoking cessation. And, we did a campaign, particularly during the Stoptober time. And we've been doing a lot of other work as well around developing smoke-free zones in some of the public health areas, because of course, some of that is not necessarily in the legislation, but, with a good evidence base, I think, we can influence what particular settings can do, as well as offering additional support for people who are smoking within those particular settings. So just to close, what have been some of the challenges that are relevant to these 3 risk factors in Richmond and Wandsworth, and some of the kind of policy changes that we think will be helpful? So all these 3 risk factors are priorities for us in our joint local and health and well-being strategy. And, some of the key challenges are around healthy eating. So whilst levels of obesity are lower in my two particular boroughs, we still have a challenge because we know that nearly half of adults in the boroughs are overweight or living with obesity. And the challenges that brings, there's a doubling of the rates of obesity between reception year and year 6. And around alcohol in Wandsworth, alcohol-related mortality is higher than the national average, and the figures in Richmond have been rising. Smoking is still an issue, and although our rates of, the prevalence of smoking in adults are lower, there's still significant numbers if you think about it from a population perspective, and there's still a lot of work to do in that. So our challenge in learning is obviously public health is an art and a science, but through embedding our prevention framework, I think it helps to help the wider council to kind of see that health is relevant to everyone, and it gives them a mechanism to try and think about how they can influence health through the wider determinants. We have actually produced a toolkit that we sit down with council partners and we try to help them think, how they can embed that prevention framework in some of their work. And I suppose just one final thing is from a national policy perspective, particularly thinking about healthy eating and alcohol, I think it would be useful for local authorities to have greater powers to limit advertising of unhealthy foods and alcohol beyond council-owned sites, which is the area that we're currently able to affect. Thank you.
Thank you so much, Shannon. So we've heard from Alice about a plea for health as a licensing objective, and from Shannon as a plea for the ability for local authorities to restrict advertising of unhealthy food in places where they don't have direct responsibility. So come to Janelle, who's also previously been president for the Association for Directors of Public Health and a director of public health herself in Tameside and in Haringey. So over to you, Janelle, for a bit of a perspective on where you are now and also on your experiences. Thank you.
Thanks so much, Adam and Alice and Shannon. And I mean, it's fantastic listening to what's going on in local government and also just to see the very interactive Q&A. There's a lot happening, there's a lot of energy, and it's a real demonstration of what can be done locally. And also, I think that interaction between national and local, and of course, regional plays a role as well. So delighted to have been invited here. Thanks very much, Adam and the Health Foundation, for taking on this work, really, because I think it's really important to continue to push on in terms of what should and can we be doing locally or could be done locally, what more could be done, and how can we enable that. So I think in terms of my new role, having been a Director of Public Health, now Deputy Chief Medical Officer, and I'm the professional lead for the Office of Health Improvement and Disparities within DHSC. It's a time when we've got a new government, we've got many manifesto commitments that talk about prevention, that give clear calls for action in a number of areas, including tobacco and unhealthy food, which we're focusing on. And so it's really an exciting and a new time to push on in terms of improving health. Importantly, I think for me, is that there's a clear signal that very often it isn't actually about individual choice, but particularly the current example around the tobacco industry, it's very much that population level focus that you spoke about, Adam. It's very much about saying this isn't about individual choice. This is about people's choice being taken away from them as they're addicted young, or indeed their choice to breathe clean air around them taken away from them through if there's passive smoking. So really, for me, it signals this recognition that you need national regulation of an industry that sells poor health and early death. Since the election, the OHID within the department, we've been supporting work on the different options to deliver the health mission. The overarching goal is to both shorten the amount of time that people spend in poor health as well as reducing premature mortality. So it's the both and, because actually we know that those in the more deprived populations living in the more deprived areas are not only likely to die younger, earlier, so they're not only likely to die younger, but actually live for a longer period of time before they die young in poorer health. And that health inequality has got profound implications for our society in many different ways. And we need national and local government leadership in terms of tackling and addressing that. So Department of Health and Social Care, which is the department in which I'm based, has a lot of those policy levers. So I've just spoken about the Smoke-Free Generation Bill. A lot of the policy levers are also are though in other government departments. So planning is led by MHLG, food by DEFRA, alcohol is Home Office. So I think it's just helpful to recognise that some of the policy levers sit within other government departments that aren't, that will have a lot of goals and objectives themselves. Health might not be the foremost one. So I think the mission led government, or the way that the government is focusing on the five missions, health being one of them, is a really important way to try to enable government to work more collectively, to collectively deliver on those missions, to really understand how they interconnect and how we can do things that recognize. I think, Shannon, you talked about there can be tensions between, for instance, an opportunity, a growth mission and a health mission, but how do we collectively across government recognize those tensions and actually come up with the best things for our populations? So I think I think that's quite important to recognize it. And I think local government, and particularly my experience of local government, is that ability to have those conversations, to really engage with those tensions and understand how things land in a local place, to make sense of how things land in a local place. It is in some ways easier to do that because you can see how things quite specifically connect with local populations. It can be a little bit more challenging nationally, but certainly that's the aim of the mission-led government, is to really grapple with those tensions and make a difference. And so we're very, very helpful in terms of engaging or connecting across government to make those difficult decisions, policy decisions in the current environment, to bring about change. Because we know that national legislation and regulation can make a huge impact. I think, Alice, you mentioned the 2007 smoke-free workplace. I mean, that was a real step change in our smoking prevalence. So that recognition that national policy can make a huge step change difference is important. But then also you need oftentimes new national legislation around local powers to act, because as you guys have been talking about, there are already a lot of local policy levers to make change locally, and some great examples coming through. I mean, health is created fundamentally by local communities, local environment, local place in which we live, and local authorities with partners and community organizations, local NHS, all have that role in really being able to collectively look at how you might do things differently. But we've also heard how there might be some challenges, or how it's not always that easy. And so what new regulation or powers might there be that we need to take action on nationally? You've also talked about the difficulty, and I've seen quite a few comments in the Q&A around capacity, local capacity, not just in public health teams, but also this isn't just a public health game. This is also about trading standards officers, environmental health planners, and others within local government teams. And it's both the capacity to do things and the capability, that knowledge, skills, experience, that is needed, as well, I think, as just that confidence in using powers and levers. You've also touched on, and again in Q&A, it needs political will. So I think how you work with politicians is really, really important. And Alice, you mentioned educating or supporting your local politicians to understand what's going on in terms of rising levels of obesity and overweight in the community. That kind of work is really important. And that work with politicians who are representative of local views is important locally, but also, I think, even when we come to national legislation, like the smoke-free generation bill that's going through now, those local councillors and local MPs who are influenced locally have a huge role nationally. So that political will, you'll see that locally, but also it has influence nationally. I did mention that there've been a few examples given that the view that current powers may not be enough, might not be sufficient. I think we need to be really clear where that is the case. There will be a charge that, well, you do have powers already that you could use. I think if those powers have been explored in particular areas and have been successful, Alice, you've talked about that in Gateshead. Why are they not successful in other areas? Is it that we need further powers, or what are those real barriers? Because we need to develop and build a clear evidence base to make the argument nationally to have more powers. There is a balance really in terms of this, about how much does national really determine the detail on powers for local, or how much do local determine how it's relevant to themselves. And there is, I think, a balance to be struck between national being prescriptive about what happens locally, and locally needing flexibility about how things land. So I think there's also it needs to be a sophistication about that tension, and so where local is calling for more powers, I think really exploring why current powers are insufficient and what new powers would actually do, would really be looking to you to help build that case and enable arguing for new powers. And of course, any new policies or legislative controls need to take into account that, what I mentioned before about capacity and capability. And so we need to pay attention nationally about how do we fund or support local implementation of any new powers, and indeed any new burdens. But I think, Adam, I'm keen for us to have some discussion, and I think folks have heard a lot from us. So I'm really keen to have more conversation in terms of the Q&A about some of the ways in which we nationally, what we need to hear from you, what more we can do to help support. And I think and then also I've mentioned a few things about what you can do locally to support us nationally, building the case and so on. I think, Shannon, you also talked about local innovation, and again, pushing the boundaries of what can be done locally, showing what works, so that we might look at doing something nationally as well. So innovation starts locally oftentimes, and I think that's really important. Capturing the evidence base, really important. Because fundamentally, that evidence base is what really helps shape and drive forward our ability to bring about regulatory change.
Thank you, Janelle, and thanks to all our speakers. And thanks loads for the conversation that's going on in the Q&A. And I see people who are here as attendees answering one another's questions and sharing good practice. So that's perfect and really lovely to see the opportunity for that to be done. So I'm going to come to a few questions, that's okay, in the last 10 minutes or so. And I'm going to start with a question that's had the most thumbs up, if that's all right, which is about how local leaders and local officers can work with their councillors and politicians to bring them on side, and particularly where there might be tensions between the potential commercial opportunity or interests of a local high street or a business, and particularly in places where there might be boarded up shops and that local street scene versus a potential conflict with public health when it comes to that shop being occupied by a hot food takeaway that's potentially selling unhealthy food. And the main thing I want to kind of put in this is that obviously people's local authority political context varies massively, and some of those tensions are felt more strongly in some parts of the country than others. So maybe if I come to Alice first about her experience engaged. Oh, Shannon's got his hand up, even perfect. Okay, great, go for it, Shannon.
Alice, did you want to go first? Okay, so I think some of my experience has been, when you're working with cabinet members or lead members, whatever you call them in your local authority, a fundamental aspect is that they want the council to function in a coordinated and collaborative way. So I think that's one thing that we've really got on our side. If you've got councillors who want all the different parts of the council to be talking to each other, it then kind of makes it easy to have the conversations where you're weighing up the different interests and thinking about, as a collective, what would be in the best interests of residents, and kind of, what considerations might outweigh the others. So I find particularly our health in all policies approach in Richmond and Wandsworth has been really helpful for a tool that our lead member for health can then have conversations with their, colleagues in the cabinet in terms of actually if there's a conflict of interest around a particular issue, have the health objectives been considered around that and the potential detrimental effects. And actually, I've got a good example where, as you know, there have been a lot of pharmacy closures up and down the country. And in one of our areas, there was actually an application that was received for change of use where a pharmacy had closed, and the Health and Wellbeing Board was trying to actually support another pharmacy to come back, to occupy that premises and take over. But a fast food application had been received around that. And I think, because of the kind of health in all policies approach, there was a really rounded discussion around, what the council is trying to achieve, what's best for residents.
Thank you, Shannon. Alice, did you want to add anything to that?
Yeah, because I guess this is a challenge, and you're right, it is different in different areas. And I guess our starting point is that we are apolitical, so whatever colour of local government we're working with, we've got our public health responsibilities to present the evidence and what really matters. But I have to say, my experience of local members has been that they really care about their local residents. I know that won't be across the board, but I think in the vast majority of cases, people really care about their local residents. So for me, there is something about knowledge and awareness of this as an issue of those commercial drivers of ill health. And I think that starts and needs to be considered in a range of levels. I mean, at the moment, we have a public health training plan that doesn't actually address the commercial drivers of health. So if we haven't got the public health staff and public health teams skilled up to sufficiently navigate some of these local decisions and discussions, then I think that's a challenge. So that's something for us. I also think there's something about community and the community voice. I think that's been mentioned by both Shannon and Janelle. And again, working with local communities so that we can dispel the myths that are around individual choices and actually demonstrate how commercial drivers and commercial interests have influenced the decisions that we all make as we're in those communities. And I think, that is a challenge because commercially, they've developed this great framework around it being, back to individuals and not about policy decisions. And we know that the reason for that is around vested interests in profit. So, it's not an easy task, but I think it's one that we need to be mindful of. And so, being able to have the workforce that's skilled to be able to have some of these conversations and be able to reach into communities. Because if communities ask for things, then it's much harder for both local and national politicians to kind of ignore that ask. So I think that we need to not underestimate the impact that we need to have in building knowledge and awareness around this at a population level. I think that some of the commercial arguments that are used are just not found to be true in reality. So certainly I know that people were concerned about the fact that if we refused hot food takeaways, that we would suddenly have this increase in kind of empty shops, and that would drive down the economic prosperity of an area. And what we've actually seen is the opposite, because we also acknowledge that hot food takeaways are not always good for the economy, both in terms of individuals, but equally in terms of, they're smelly, they create loads of litter, they're not particularly attractive in terms of the, the places that other people want to set up. So, certainly there's evidence that shows that we aren't seeing an increase in, sort of empty spaces as a result of that. So I think, it is about being able to have some of those discussions. But then I think if we think about this from a whole community perspective, for example, I think it's 46 billion pounds, for example, that tobacco harm costs us as an economy nationally. So actually the arguments around that commercial benefit, really are paled into insignificance when we look at the harm. And in a similar way, we've got that with, alcohol, so there's been some local work that's been done by the Institute of Alcohol Studies, which has provided analysis for every local area in the country, I think, around the amount of money that is spent on alcohol harm. So for Newcastle, it's 181 million pounds is spent locally tackling the issue of alcohol harm. And actually a lot of that is within the economic space in terms of productivity of people and, and illness and, being out of work sooner because of illness associated with alcohol harms. And, but again, it is about us being equipped with all of that knowledge and all of that information so that we can start to have some of those discussions and debates at a local level. It's not a pure science. So I loved it when Shannon said it's about the art and the science, because I think that's important too. And we forget that sometimes. So for example, there was a discussion around whether we would have a World Championship boxing event in Gateshead. It was going to be televised, but it was going to be sponsored by one of those awful money lenders that had the high. It was a few years ago. And the discussion we had locally is, what does it bring to the local economy and what's the harm that it will cause? And recognizing that actually if we said no to it, it would have moved to one of our local areas and but it's televised, so all of our residents are going to be exposed to that marketing anyway. You then start to do that weighing up of whether it's more beneficial to the economy or more, and less harmful. On the other side of it, the Coca-Cola truck is a great example of where we would just say absolutely no, because, kind of what's the benefit, and it is just about marketing for Coca-Cola, and, people might go along and get a free can of Coke or what have you, but that's not significant enough for us to be able to support that at a local level. And so again, it's nuanced, and that's where you come to the art of this, is having those nuanced discussions around what works in a local area. But I definitely think the important bit is that advocacy and that knowledge and skills to be able to have some of these difficult conversations, because they are difficult at times.
Thank you, Alice, and thank you, Shannon. So I'm aware that it's just hit midday, so we're going to do a very quick whip round, and then we'll say thank you to everybody who's dialed in. So my one question to all the panelists is, what is top of your policy wish list for 2025? So I'm going to come to Janelle first, if that's all right.
Thanks, Adam. So a chance for me to alert folks. We've talked a lot about fast food takeaways. The National Planning Policy Framework is out to consultation till the 24th of September. There is an opportunity there for you to comment on the fast food takeaways. I think it's chapter 8. So please use the opportunity to do that. And then I know a lot of you have been asking for health as a licensing objective. We've talked about it on this call. So again, we have had lots of conversations about that. It is about developing evidence base. We're looking at Scotland, so continuing to work on that. And I know we haven't talked about it really on this call, but I think colleagues have made made a case around trying to get licensing for tobacco. So that is part of a mix and part of a consideration, as Alice put out, the pros and cons of, as I've also detailed, of having national legislation on some of these things. And how they might be implemented, what impact they might have, and also are there downsides to what we might do. But those might be three, Adam, that we're certainly discussing.
Thanks, Janelle, and that's really encouraging to hear. Shannon.
Thank you. So just going on from my example, I think it's really hard work for local authority public health teams, trying to retrofit and influence, local policies and strategies that are based on national frameworks that have already been set without considering health. So I think my one ask would be if at central government level, there was a health in all policies approach across some of the national legislation that would make it easier for local authority public health teams to go into an open door in terms of trying to influence what needs to happen locally. Thank you.
Thank you, Shannon. Alice.
Thank you. And it's hard to say one, isn't it? So I'm going to sneak it. So obviously we've got the tobacco stuff that we are anticipating coming out in the next few weeks, months. We need to get behind that is kind of the first thing. We need to be really strong in supporting the work that's happening there because it's kind of game changing for the generation. Alcohol, there is so much evidence base around what we need to do. So, my ask would be that we have not one policy objective, but we learn from, the kind of price, availability and promotion, and we do take action on all of those things in relation to alcohol as well. And then I also think there's one which kind of sits across everything. So apologies, it's three, but I think we need to protect health policy from industry influence. I think when we saw that with tobacco, with the Framework Convention on Tobacco Control, we started to have a different conversation around it, because it is not right that industry that produces and promotes harmful products are round the table more than public health experts are in shaping what that health policy should look like. I wouldn't seem to be shaping an industry promoting sales and marketing. That's not my expertise. So why are we allowing them into our space in terms of advising on health policy? So protecting health policy from industry influence would be a real key one for me.
Thank you, Alice. And my mistake, I thought we had to wrap up at 12, but we've got another 5 minutes. So we've got time for another question, which is great. So there's been a few people asking about, particularly on the unhealthy food side of things, there's one thing about ensuring that we don't have new planning permission granted to premises that are selling unhealthy hot food, particularly near places like schools or in places with high levels of obesity. However, how does the role of the proliferation of delivery companies, whether it's Deliveroo or Uber Eats or anything else, potentially conflict with this? And what should we be worried about, if anything, at this stage? So I don't know whether that's maybe one to come to Janelle first, and then maybe Alice and Shannon might have some reflections from local experiences.
Thanks, Adam. Yeah, so I think it is something to be worried about. We know that what is driving the increase in obesity and overweight is simply a real increase in calorie intake. And we know that an out-of-home meal is about twice the calories of an in-home meal. And actually, the takeaway, so if you take a takeaway pizza will be more calories than, for instance, buying in a supermarket pizza. So the out-of-home, in terms of the fast food takeaway and the rise of that is really very concerning. We also know that concentrated in particular areas of deprivation. And in fact, I think there's been recent research that has shown that has increased even more over the last few years. So it's certainly of concern. Again, it's probably a place for innovation locally, for really understanding what's going on locally, what powers or ability might local areas need to try and reduce proliferation. And again, I mentioned about the consultation. So I think it is an area that is very challenging for us. Industry works very quickly, whereas actually regulation legislation works really quite slowly. So be interested in views, evidence base as it develops, but clearly a real area of concern for us.
So we want to watch. So Alice, how has this clashed with some of the work that you've been doing so well over the last 5 to 10 years in Gateshead?
So absolutely share those concerns. You know, it is a pressing issue for us. I guess the one thing I would say is that one of the bits of evidence that we used from Cambridge was around exposure to hot food takeaways driving consumption. So you're more likely to consume food from hot food takeaways if you pass lots of hot food takeaways on your way home from work, for example. So even reducing exposure will reduce somebody's likelihood of consumption. So it's still something that I think we should be doing. But I mean, there are issues around, you know, sort of dark kitchens and, you know, sort of people being able to provide that delivery. And I guess the challenge that we've got now is the advertising and the real proliferation of, you know, kind of the Deliveroo and Just Eats, and they're everywhere, and, you know, all on our social media. So it will be, it is worrying to think that that will also be driving consumption. I mean, that as Janelle said, industry always steps ahead of us because they've just got more resources than us. So every little bit that we put in place, they try and find a way around it. But I guess, again, going back to the journey on tobacco, it was a comprehensive, multi-pronged strategy that was needed to tackle the issue of tobacco. We're still not there, but we're in a much better place than we were several decades ago. So it's not losing sight that these little steps do add up to a much bigger picture at the end of the day. And so it's not to not do it, but it is to, you know, continue to reflect and refine those policies as you move forward. I mean, like I say, planning is always a looking ahead tool rather than looking back. And like I said, in Gateshead, we already had way too many above national average, and we haven't, you know, we have reduced the number, but we haven't solved the problem by any stretch of the imagination. And so, again, not selling this as a single silver bullet, it requires a multi-pronged strategy to be able to tackle any of these issues. But just don't get thrown off by the if that doesn't do it on its own, then it's not worth doing argument, because again, that's another nice one that industry have managed to throw our way.
Thank you, Alice. Sian, I don't know if you're able to add anything to that, and whether you've been able to engage with any of the dark kitchen industries in your local areas as well.
So we haven't necessarily engaged with dark kitchens. It's an interesting term, actually, that I'm hearing for the first time. But, you know, I don't really have any silver bullets around this. But I think, as Alice mentioned, what we need to continue to do is to try and tackle, you know, tackle the bits of the system and the industry that we can. So, for example, you know, if we reframe it and think it's not just about the delivery, but it's actually about the sources of the food and where it's produced, then that would reframe where we need to concentrate our efforts in terms of what we can do, whether it's around regulation or, you know, just around influencing sort of healthy choices. So some of the work that we've been doing in Richmond and Wandsworth is we've started to use the council's advertising spaces to just try and reintroduce things around the Eat Well plate. And we've done some work with the British Nutritional Foundation to try and produce culturally relevant eating well plates that appeal to some of our different communities, and just trying to balance some of that advertising of the fast food, and, you know, that is easy to get and proliferated everywhere.
Thank you, Shannon. That's great. And then there's another question which I know's had a few people thinking, and Janelle, you've mentioned about the potential opportunity that health as a licensing objective might have with the current administration. Do you think this is likely to be a signal that we could perhaps have a renewal of an alcohol strategy for the first time in over a decade?
No, I don't. Well, that's a leading question, because either say there isn't or there is. But no, I don't think so. I think the recognition that there is a real problem in terms of alcohol, and that, you know, that the harm is known, it is understood, and I think trying to think about ways in which, if we take the local areas, can address some of those shifts in alcohol is quite important. So one of the major shifts, which I think is worth looking at, is that shift from drinking in pubs, so the on-trade, to off-trade at home. And so we know off-trade, supermarkets, other off-licenses, sold about 83% of alcohol in 2021. And we know that higher risk drinkers are estimated to purchase about 3/4 of their alcohol in off-trade. So what does that mean in terms of our licensing and what we can do about licensing? And I think when I speak to directors of public health, when they've spoken to us, it's that concern that it's not necessarily the on-trade that creates those problems, that threat to community safety or children, public safety or children, but it is more just that saturation of off-trade, particularly in areas where there are more likely to be higher risk drinkers, that is of real concern. So what I was saying is that recognition that there's an issue, looking to Scotland, where there has been health as a licensing objective, which has, to be honest, mixed reports, but really looking to the evidence base, and thinking about how that might work here in England. Again, just I started the conversation, or my input, and Adam was saying that different government departments lead on different areas. So Home Office leads on alcohol. The mission-led government provides further opportunity for us to work across government, to look to those other government departments who might not have health as their primary objective, but to think collectively in that trade-off, in the same way that Alice and Shannon have been talking about locally, just that pragmatic recognition that there is always sort of trade-off type conversations. There's a bit of a tension, but how we are placed to have those conversations, working with Director of Public Health colleagues who are calling for health as a licensing objective, and see whether we can have influence to bring that about.
Thank you. And that cross-government piece is going to be critical. Alice?
I absolutely agree with everything Janelle said, and I guess that if you look at the pandemic as a almost like a RCT in some ways, that at a national level around, we closed all of hospitalities, yet alcohol harm massively increased because people were drinking at home in a way that they just weren't drinking, before that. And obviously, routines disrupted and all sorts of other things going on there. But I also think if we take the public bit into it, the public, are not necessarily with us on the kind of anything that would impact on their pubs. So let's work with what we've got at the moment, and actually being able to tackle the off-trade, I think, would be something that would be really significant. We do need the Licensing Act to change to do that, because at the minute it's kind of, we look prospectively almost at a new license application and then try and link it back to the harm that's in that area. Licenses that are on trade in some ways have many safeguards around them, because if that premises is seen to be serving alcohol to somebody who's intoxicated, we can locally review the license, and if there's lots of problems at a particular pub, you can't do that with off-trade stuff. So people can go to the pub, to the supermarket, buy 4 bottles of wine, go home, drink the bottles of wine, beat the wife, or whatever it is, and it's never tied back to the supermarket where the product was bought from. So I do think there's a discussion that we could be having at a national level around how we focus slightly differently on and off trade, that may be more politically acceptable and maybe more palatable to the public. And I know we all understand that no level of drinking is safe, but actually there has to be something about taking people with us on this journey as well. And so, I'm not saying that that's a perfect solution, but it's certainly something that we could think about in terms of being more pragmatic. And I think the work in Scotland, is, obviously they've got licensing objective, health as a licensing objective, and MUP, and whilst they've still got really high levels of alcohol related deaths, actually they'd only seen a 9% increase in alcohol related deaths, but we've seen a 36% increase in England without having that. You know, so I think that so whilst it's not, like I say, there's no silver bullet here, it is about having those measures in place, and it's really clear that some of the work that's happening in Scotland is impacting on a reduction in deaths.
Thank you, Alice. So we've crashed the pips. It's over 12:15. Thank you so much to our speakers today. So to Shannon, to Alice, and to Janelle for their time and their hugely thoughtful and considered responses to the topic posed and also to your questions. Thanks so much also to all you who have taken part and shared your thoughts in the Q&A. And I'm sorry we've only been able to get to a few of the questions, but inevitably there's still far more to continue with the discussion beyond just this particular hour or so. So this is just to remind you that the slides and a full recording of the webinar will be made available on the webinar website shortly after this finishes. And otherwise, I think there is hopefully a screen going to be put up in a moment by Edvi, one of our colleagues, just sharing some links to some of the bits that we've spoken about today. And again, we'll make sure those are on our website for you to be able to find easily enough soon after the recording. So without anything else to say, thanks to the Health Foundation team for putting this on. Thanks to all of you for being involved. And there's plenty more information about future webinars and also the breadth of the work that we do at the organisation available through our website. And have a lovely rest of your week.